Today I'm going to talk about a case of post-AVF limb edema. He's a 55-year-old gentleman presented to us in 2023 with CKD5 ESRD. He was non-diabetic, not willing to undergo transplant or peritoneal dialysis, so hemodialysis was the only option. We did right IJV TCC and left RCAV was created. Patient came back after 1.5 months with CRBSI, so TCC was removed and CRBSI treated, and cannulation was done in the fistula successfully, and he was sent home. He underwent hemodialysis for almost a year and a half through the fistula, and then it stopped during an unfortunate episode of hypotension in the dialysis. So in his native, right IJV DLC was inserted again, kept for 2 months, and left brachiocephalic AVF was created, which had primary failure, and then left BBT was done, which functioned for 4 months, and then an infective aneurysm was formed and burst after which right IJV TCC was done again, and BBT was closed on left side. So patient came to us with 2 month right IJV TCC and CRBSI with no flow in the tunnel cuff catheter. So the current clinical problem was whether to change the right IJV TCC to TCC over wire, change right IJV TCC to TCC and create AV fistula, or change the TCC to DLC and create AV fistula in the right upper limb. We chose the third option, and we did diet study of double lumen catheter when we changed the catheter and took venograph of the upper limb to see for the possibility of fistula and the condition of outflow vein. So this is the maximum contrast image of the vein. Here we can see that here we can see there is some stenosis in the brachiocephalic and SVC junction. So we told the patient that you might require a procedure in future. At the time, patient didn't have any edema on the right arm or forearm. So his fistula, brachiocephalic fistula on right side was created, but on the very same day, patient started having edema. This is the first day of edema. It actually worsened after that. He started having edema over the hand, forearm, and arm on the same day. So we did CT angiography on the third day, and it showed that there was a thrombus in the cephalic and brachiocephalic junction, and also stenosis in the cephalic vein. And there was a thrombus in the IJV also, and stenosis because of the same. And there was stenosis at the SVC and brachiocephalic venous junction. So what we did was we continued the dialysis through the catheter. We started anticoagulation, and we gave 2.5 weeks the fistula to at least partially mature. After that, we took him for intervention, and this is the first we inserted a 10 French sheet through the femoral root, and this is the dia study from the femoral long sheath. We took a 6 French sheath through the fistula, the cephalic vein, and this is a dia study from the same. So here we can see there is a stenosis at the brachiocephalic and SVC junction. So first we took a 10 French sheath through IJV where we already had DLC, and we dilated by 8 mm balloon. After which, through a microcatheter, we progressed PTCA wire, and after partially deflating the balloon, the wire actually passed also. So here we can see the choice PT wire, but unfortunately, the wire inserted in the vein was the tip was the reverse side. So we were not very sure we should proceed with the procedure. So we took the wire out because the reverse end is a bit stiffer compared to the tip. Here we can see the dia study. There is a stenosis here at the brachiocephalic SVC junction. Then we again inserted the wire, but this time the wire didn't go in the SVC. Here we did uh, plasty of the junction by 3 mm balloon. This is the dye study after 3 mm brachiocephalic vein SVC junction balloon. So now we are seeing stenosis at the level of cephalic vein also. So then we did angioplasty, venoplasty of cephalic vein by 3 mm balloon. Then we did cephalic vein plasty by 4 mm balloon. Then we did 5 mm brachiocephalic vein SVC junction plasty through the fistula. Then we did brachiocephalic venous plasty and 5 mm cephalic vein plasty. So this is the dye study after AVF and outflow vein plasty. Still, we can see there is some stenosis at the level of brachiocephalic vein and SVC junction. So what we did was, this is the site of stenosis. So what we did was, we inserted a snare through the femoral root, and we caught the wire which was there from the fistula side. And as we could not pass a larger balloon through the fistula, it was a very naive fistula. And the stenosis at the cephalic prevented us from having a 10 or 12 mm balloon. So we caught the wire with the snare and took it out through the femoral sheath. And now through the femoral root, we did a 10 mm balloon plasty at SVCB brachiocephalic venous junction, and completely dilated that junction. Here we can see the balloon wasting. And after this, we did the final dye study, which showed good flow at the junction and all. And then we took a femoral route for dialysis, as patient had edema already in the right arm. So this is the patient's condition today morning. His edema has reduced in the hand, forearm, and we can see the wrinkling. There is slight edema here, but there is no edema here. The edema in the arm probably might be because of extravasation of the dye, which was there during the fistulogram, uh, which we did initially. There is no pain currently, good thrill, and flow is also good. So the discussion should be on, should we do CT venogram in all patients who had previous history of calculations before creating AVF, or at least a conventional venogram in the cath lab? If we objectively find evidence of stenosis, which is structural, not symptomatic, then should we do a pre or post AVF intervention? Should we do it pre-procedure, pre-AVF, or post-AVF? And I would like Dr. Hardik Patel to share our experience also. Thank you.
I hope this must be sir, I am audible, right?
Yes, Hardik, we can
Yes.
hear you.
So I think this is a common question which keeps coming when patients comes with a IJV, which is infected thrombos, and surgeons are willing to do or we are willing to going for a fistula in the same arm, and we inside we know that this patient is going to come back with venous hypertension. So how many of us they avoid doing fistulas when we know there is a central venous stenosis, or do we do consider doing plastic before or after the fistula creation? Because sometimes there is a confusion if you do the plastic before creation of fistula and then the fistula is not working and fistula may not mature also. So why to do plastic at all? And sometimes after creation of fistula, patients suddenly develops limb edema, and then you are worried that this may again create problems for the patient. So what is the general practice across the uh, forum? I wanted to understand. In my own experience, I have seen this happening 4 times. We knew that the patient has central venous stenosis. We created fistula on the same side. Fortunately, at least three patient I was able to do plastic afterwards. One patient at 10 days earliest, and one patient at the end of month. And this particular patient we did at 20 days. So allow it some time to mature vein to mature, and then do the interventions. So that gives me one more access to do interventions, and at the same time. It gives once the flows are there, then the fissure sinus is also going to remain open for a long. So wanted to understand the from the other experts, and what is your take on this particular kind of situations?
Yes, comments.
So, I think this is a very, very interesting question. In fact, Hardik, before this meeting started, I was discussing the same with our panelists that, I'm actually planning to do a small study on this aspect. Like, my proposal is that we screen the central veins after the catheter is removed, and then if you find any opacity, do a preemptive plasty, and then we should try that, because this is a burning question. Although the literature says that you should intervene only when there is a lesion, but I think that article was published as a retrospective study. None of them have looked up prospectively about these cases, like what is their course. But yeah, I think in our scenario where CRBSI is very common, and the incidence of central vein stenosis is also very common. Like, in our study, we found that the stenosis rates were almost 24%, directly proportionate to the incidence of CRBSI. I think it would be a good idea to preemptively do plasty, so that we mitigate this central vein occlusions. This is my take.
So,
But sometimes the problem is you it's difficult to do interventions when the veins are not dilated, because even after fistula the vein was hardly of around 5 mm.
No, so what I do is generally I take the brachial artery, I mean the basilic vein axis or the axillary vein axis. Okay, and then what like just you did, we could do the snaring from the femoral axis to the basilic vein axis and intervene. So there is more stability, and the majority of the times I prefer either the jugular axis if the vein is patent, or the axillary vein axis, so that the route is very short and then we can quickly get around the lesions.
and Hardik and Akash, see, you could approach through the femoral vein. That guide wire wouldn't go because you had already made some dilatation of the right subclavian and brachiocephalic. So, won't your didn't your guide wire cross it from below? Why you had to snare it from above, and then say the case we did
Yes,
now.
sir. We kept on
But
trying from femoral. We are
uh,
not able to find that particular lesion. In fact, we failed to demonstrate. Our wire was not crossing even from fistula side. So we did a larger balloon dilatation from the IJV side,
mm,
because we for that particular purpose I never removed that IJV catheter, because I knew if once I remove the catheter I may lose that access also. So I kept that IJV purposefully, despite patient having CRBSI. I kept changing that. We changed it for twice when patient was having fever, and this was step 4 years. So again, that was more worrisome. So purposefully kept that IJV, so that I can use whenever there is need to do plasty. So after doing plasty from the IJV side, then only we were able to cross the lesion from above. From below, I kept trying, but I was not able to cross.
So here in the first slide, sir, where we can see that first we did plasty by
by the arm.
a 8 mm balloon through the IJV. There
Was
here we can see the wasting. So there was a stenosis at the IJV brachiocephalic and subclavian brachiocephalic junction, and the brachiocephalic SVC junction also. After this, we were able to pass the choice PT wire with partially deflated balloon in the SVC.
Even the cephalic arch stenosis is very, very notorious. It never allowed me to pass a normal balloon. So I took a PTCA balloon, and at least with that, I was able to cross the other balloons. Otherwise, it was very difficult for me.
Mhm.
So this stenosis, this is actually a, it was more difficult compared to what it appears right now.
Mm. So the snare can bring it through the femoral sheath, is it?
Yes, yes. So we bring it up. We bring out the snare to the femoral sheath,
Yeah.
and I use that extend length wire of a longer wire. So I can hold the wire from the both ends. So this becomes more stable circle. So you can do balloon dilation very easily, even with a glide wire also.
What is the size of the femoral sheath you used? I heard it
So
as
these are long sheets. Generally, these are available at 8 and 9. I don't think beyond 9 is
Yeah,
available.
yeah, 90 centimeters, sir.
Yes,
They are
75
available as
centimeter.
45, 60, 75 and 90, sir.
So generally, I keep 60 and 75 with me.
Correct, correct.
So
Yeah,
even
yeah,
you can keep it slightly outside if that it is too long.
yeah, yeah, yeah.
And sometimes this dilator of the sheath can be used to cross the lesion. If
Correct.
because it's quite straight.
Yes,
So
yes. Yeah, because of the coaxial shape, sometimes that also helps like a guiding catheter for us.
and it's straight. So if you are going for IJV, then it becomes easy.
Correct.
okay. I think we had good discussion. This is just to show you the picture of that man.
Yeah.
Uh,
The left IJV, which you
Bala sir, one question that came up was what happened to the BP after you opened up both the renal vessels, sir?
arteries. Yeah, it's 130, 90.
he mentioned 130.
Oh, yeah.
Yeah, and he's just today the output has become 1,000. Uh,
Okay.
but we are taking him for dialysis today without much fluid removal because his
Mm.
potassium was high.
We
Yeah, yeah.
had
And
one
someone,
anecdotal case of a similar kind, one where one side nephrectomy was done and other side there was stenosis. People did attempt it, opening that up a year ago, but they failed. Then he was on dialysis for a year, and he came to us after a year for uncontrolled hypertension, and it was CTO. We opened it up. He became off dialysis almost after 20 days, and he remained off dialysis for 2 years after that procedure. Unfortunately, he had a malignancy which recurred and of a kidney, so he is losing that kidney again. But it was again very even when during procedure, I was quite I was sure that he is not like going to get benefit any of doing all procedure, but he wanted to get that renal artery opened up, and he became off dialysis after 15-20 days. So yes, it works for many patients.
Yeah.
yeah,
Unfortunately, those studies are very biased because they choose patients based on the imaging rather than clinical features. If you choose
correct.
patients on clinical symptoms, they definitely get benefit.
No, on the same note, Hardik, even the paper which said that central vein interventions should be done only in symptomatic patient, that was also a retrospective study. They just went through the records of the patient and they came up with the conclusion. I think unless we do some prospective study, we are not going to have the correct conclusions on that. Uh, and someone, Bala sir, someone was talking about the risk of the contrast when you do these renal interventions when a patient is dialysis dependent. In the chat box, we have a question on that.
No, we generally don't worry about contrast
Don't worry.
in renal
Correct,
stenosis.
correct. Because anyway, the patient is dialysis dependent.
No, even
So,
Even if
recently we had a graft of renal stenosis. Patient had a
mm,
create of 6, because then also we went ahead and did a CT angio, and then also say plastic, because for graft we want to know the anatomy before we intervene.
okay.
The
So we
logic
did CT
is,
angio also, and we did a plastic also. Unfortunately,
Mm,
patient that had a AKI which was prolonged, and he improved after almost a month of dialysis
mm,
after transplant.
the
So
logic is, if there is no stenosis, then anyway is going to be dialysis dependent, so the contrast wouldn't matter. If there is stenosis and if you are intervening, maybe
he'll
that will
benefit.
yeah, will benefit. So either way, I think taking for angio with iodine contrast is not a big offense.
Even we don't do MR, we don't sit away do CT angio when
We
there is a
avoid
strong
MR. Generally,
suspicion,
MR avoid.
Mm.
because we wanted to understand anatomy much better before we do intervention. So
Okay.
planning also we do CT angio.
Okay, this is the man who was, both femoral. He had, and you see the IJV not there on either side, and he had, RCF, BCF grafts on either side. So the person with the fibrin sheath. Okay, I think
So
so.
we should all congratulate Dr. Ramkishore sir. So with his procedural experience of I think more than 10,000 tunneled dialysis catheters, he has come up with a nice modular course with all these fantastic animations and all the topics we have discussed today regarding these central vein interventions, fibrin sheath disruptions, everything. I think he's extensively covered. So I'm really excited to look into his course. I think he's done a modular course of more than 10 lectures. So I think it will be great use for the beginners and for all of us to refresh our knowledge, sir. And knowing the aptitude of Ram Kishore sir for academics, I think it's a very good course, a great initiative he has come up with.
This course, how can students join? They'll have to.
No, I think sir has just completed the complete module, sir. Maybe we should talk to him and see if Inform or Avatar wants to pick this up and then do it, sir.
Mhm. Great. I think Ramkushore is now very much with us in our WhatsApp group and the meetings. I think
Yes, sir. Yes, sir. No, he just sent me this video. I was very excited, and I thought I should share this. Uh, he's done all the techniques, discussed everything very, very. I mean, I wish I had this course when I was a postgraduate.
it is in the chat box. Are there any relevant questions to just quickly?
uh, so,
Sir, good evening,
Dr.
sir.
Sai, yes, sir.
Yes.
Sir, this is Santosh here, sir.
Yes,
Yes.
Santosh.
Sir, good evening, sir. Good evening, everyone. Sir, I just like to convey something, sir. With your permission, Bala, sir.
Yes.
May I,
Please.
sir?
Yes.
Sir, so, sir, regarding the second case which was presented, which had a CTO later on, right-sided RCAVF, which was opened up, sir, discussion was going on regarding why there was no flow in contrast in the radial artery, despite having good flow in ultrasound. Sir, most likely what might have happened is, retrospectively, I'm just thinking out loud here, that probably when we're inflating the just osmotic size or the outflow, sir, sometimes what happens is a small thrombus might just get formed just at the anastomosis. So then when we're giving contrast, when you're doing reflex, then we cannot see the contrast going into the radial artery. So that might have probably happened, sir. Many a times it might be JS will go and inflate just the JS side because of that stasis there. Small clot or small thrombus just at the anastomosis or just near the proximal RA can sometimes form, sir. That might have
Yes.
probably happened. So these kind of situations, what happens is even there'll be soft thrombus, very small, but right at the critical junction, it will be there. So those times, sir, if even you just pass the guide wire inside, the clot get distorted, sir. Retrospectively, sir, I feel that might have happened. Happens many times. You will see that initially artery good flow is there, then surprisingly thrombus is there. So I don't know if properly that might have been the reason, sir.
Yeah.
And regarding the inflation of radial artery, sir, usually what we use is 4 mm or 3 mm, sir. And generally we don't go beyond 30 seconds to 1 minute, sir. And so just wanted to add, sir.
Yeah, good. We needed guidance on that. And precisely why radial artery entry is better than venous entry.
Sir, yes, sir. There was a study, sir,
Artery-
TAP study. It's about to be published, sir, done by our senior, sir, PDF before me, Dr. Hemant, sir, currently is in Bangalore. That is retrograde versus antegrade approach for RCAVL. We did it only for RCA, sir, where overwhelmingly a lot of things, sir, many parameters were taken into consideration. Ease of access, administration, outcome, exposure to radiation for the treating person, analysis assistant. Taking everything into account, sir, it was overwhelmingly in favor of antegrade approach, sir. And after that approach, sir, what we have started doing is we are no longer creating anatomical snub box or very, very distally, sir. We give little bit of place while creating the RCAF nowadays, so that it's not too high and not too low, because we'll get some amount of space for us to cannulate in case a patient needs angioplasty in the future. So we, sir, 90% of time go for antegrade, sir, especially in an immature fistula, because if you go retrograde in an immature fistula, the vein is already immature, so you're causing more trauma. Until otherwise, it's a very bad distal array. We are not able to cannulate. It is diseased, or it is very distally, and it is very narrow. We always prefer and to go via the antegrade approach, sir. We are at HEPJ, sir.
Plus, this problem of artery getting embolized.
No, sir. As sir had also
It is
mentioned,
more-
70% to 30%, sir. Proximal radial artery is the main supply. 30
Yes,
to
of course.
40% are distal array, sir.
No, what I'm trying to
And
say is that may be more
yes, sir.
possible when you are doing retrograde rather than antegrade. So if you
Sir,
do the thing, you may push the thrombus into the anastomosis and into the artery.
sir, that again, sir, whether we are dealing with a thrombus fistula or just an JS or immature fistula, sir. But what we do is, sir, the thrombus going off into the RA is very less likely, sir, because most of the time when thrombus happens, it is in the JH side, and very rarely anastomosis and RA involved. So, supposing we see pre procedure ultrasound that there is a thrombus in the proximal RA, anastomosis, and JS, then we go for retrograde approach, sir. Supposing thrombus is only there after the anastomosis and artery is paired, then we always go antegrade, sir. So it depends upon which part is involved, sir. Because if the RA is also involved, then better to go for retrograde, because then we can hook and then by balloon we can pull the thrombus out like that. Retrograde helps. And at the same time, with the proximal artery is also thrombus, outcome might not be that good, sir. So most of the time, sir, thrombus involves JS and anastomosis. If RA is involved, then we go retrograde. If it's not involved, then as much as possible, we try for antegrade approach, sir.
Yes. Yeah, but I think still this, this is a point of contention because
Good evening, sir.
radial artery, especially from overseas.
Hello, Bala sir. This is Hemant, sir. Can I just add one thing, sir?
Yes,
Yeah, sir, Hemant from Bangalore. Sir, one thing which I just wanted to add on to what Dr. Santosh said was that in the first image when we took that angio, sir, the radial artery was completely thrombosed. I mean, there was no flow in the radial artery when we began the procedure, sir. The flow was going through the palmar arch and into the ulnar artery in the initial angio. So when we opened up the vein first, it is very unlikely that the the thrombus at the anastomosis in the artery would have opened up, sir. So in that images which you subsequently, which was presented, sir, the contrast was opacifying the vein, but the washout was not there, sir. I even put that in the chat box. So there was no washout, and that's one of the reasons why you missed. I mean, it was missed to pick up the central vein because the contrast not reaching the central vein properly because there was no washout proper, sir. Because there is no arterial inflow into coming into that. Because already before the procedure only we knew that there was a thrombus in the artery. So we very less likely that just by inflating the vein that thrombus would have gone, sir.
That's why I always look at 3 on table. If the 3 is there, then you're done a correct dilatation. If the 3 is not there, then there must be some thrombus still lying there.
Yeah, yes, sir. Correct, sir.
So on table 3 is, I think, very much important.
Okay.
Yes, sir. Yes.
Right. Overall there, I mean, Dr. Lal?
Lal sir had left after the third case, I think.
Okay. I think we had a good evening with a lot of inputs from everybody, and we presenters had much to learn more than the audience. I think we thank everybody, the presenters who joined us, and I think we'll stop. Thank you.
Thank you.
Thank you,
Bye-bye.
sir.
Thank you, sir. Thank you, sir.